Well, welcome everyone. I'm Hugh Foy. I'm a board member and head of the communications committee for Physicians for National Health Program, Washington. Dr. Bulger.
Yeah, hi. Thanks for inviting me to be here tonight. Eileen Bulger. I'm now the chief of surgery and surgeon in chief at Harborview Medical Center. I was the director of the trauma program for the last 12 years. Have been there for 30 years. So it's just in my blood, and as was mentioned, had the pleasure of working very closely with Dr. Foy and Dr. Cuscieri, and I was a resident with Dr. McClanahan as well. So it's really a small world, as it were. But happy to be here tonight.
Very good. Thanks a lot. Just a few brief biographical notes. Thanks, Eileen, for sharing your CV with me. I committed all 77 pages to heart. Eileen has really distinguished herself since she came to join us as first a resident, from having graduated at Cornell Medical School, and before that with honors at Johns Hopkins in Baltimore, where she was an EMT as an undergraduate in her spare time. I don't know where she gets spare time, looking at her CV with over 300 presentations and 280 some peer-reviewed publications and numerous book chapters. Eileen has really had a distinguished career. She has led our trauma program at Harborview, like she said, for the last 10 years and led it very well. She's been a great leader. And not only is she well recognized nationally, where she's now currently the president-elect of the American Association for the Surgery of Trauma, which is the trauma organization in the United States and probably the world. But she's well known throughout the whole world for her bench and clinical research and leadership. A lot of people do that, but it seems they're always out of touch and maybe out of town. But I can say from personal experience that Eileen, in her quiet, soft-spoken, but extremely effective way, is the go-to person at Harborview. She's the person who all of us ask for advice. She's the person who the nurses want to scrub on her cases because, and in the ER, when she walks in the ER, there's just, in that chaotic environment, she just exudes an air, an element of calm that helps bolster the confidence of everybody around her to do the job that they need to do, even though we're all scared to death all the time down there. Eileen, we're really honored to have you here to speak about this horribly important but extremely timely topic. So go ahead.
All righty. Well, again, thank you for inviting me to share with you some thoughts and a very timely and very difficult topic, and not dissimilar from the topic of universal health insurance. It's a fairly controversial area to wade into politically, but what I want to share with you and hope to get across to you is that I think that there is an approach we can take to firearm injury prevention if we couch it in the realm of public health that separates us a bit from the political challenges and allows us the opportunity to potentially make some progress in an area where things have been only getting worse. A lot of what I'm going to share with you is the work of a lot of people. Often you put this acknowledgement sort of at the end, but I want to put it at the beginning because really this was, to me, a pretty pivotal moment in this process. So in February of 2019, I had the honor of helping chair a session at the American College of Surgeons, where we brought together representatives from 45 major medical and injury prevention professional organizations from across the US, as well as representatives from the American Bar Association. And we spent 2 days really working through what does it really mean to take a public health approach to firearm injury prevention? Where can we build consensus among groups that have very different feelings about firearm ownership, but feel that it's important that we tackle this problem? And out of this meeting came a publication in the Journal of the American College of Surgeons, which really has everything I'm going to talk about. So if you fall asleep or you're distracted or whatever, I would recommend that you read this paper. This is the proceedings from that meeting. It was, I think, impressive that we got all of these organizations to sign onto these consensus statements, highlighting the importance of the problem, talking about different approaches to the problem. And I think what was most important, and it's really detailed nicely in the paper, is that we described a number of public health interventions that could be done now without necessarily requiring a lot of legislation that could have significant impact. And so I'm going to touch on some of those today, as well as some of the challenges that we face in tackling this problem. So when we talk about a public health approach, I think most of us these days, at least, think about this little virus that's been troubling us for the last couple of years. And I think if you take that model of how we deal with any public health challenge, whether it be an infectious disease or an injury, it's a pretty standard approach. The first step is to understand the problem, right? To do surveillance, to find the scope of the problem, understand what the root causes of the problem are. The next step is to inform and educate. You could argue that we've not done that as well as we need to in some parts of the country during this pandemic. The next is to mobilize community partnerships, and then you want to develop and implement strategies, and there are various ways to go about it, and legislation is only one of those ways. And then you want to evaluate the outcome. So that's sort of the overarching approach to a public health problem. So we're going to start with defining the scope of the problem. And you might ask me, and many people have asked me, why are you focused so much on this when you think about the burden of injury overall and what trauma centers see? We know the leading cause of injury in the United States is falls, most commonly in the elderly, followed by traffic crashes. And then what we see in trauma centers is a very small proportion of firearm injuries. So why does it matter? It matters because firearms are so lethal that the lethality of those three are relatively equal. And in fact, in 2017, the number of deaths in the United States from firearm exceeded the number of deaths from motor vehicle collisions for the first time. And it is now the leading cause of death for children in our country. So it has become a remarkable, sad increase in the burden of death. And this does not account at all for non-fatal firearm injuries. The challenge is, of course, that most people who die from firearms die before they ever reach a hospital. And so we don't have the chance to see them in our trauma centers to intervene. And so injury prevention is our only hope to really tackle this problem. So what does it look like? This is the latest year of full year of data that we have, which is from 2019. I'm backing up to the bigger problem of violence because I really think that we have to put firearms in that context. And when I talk about violence, I'm talking about either violence against oneself, which is suicide, or against others, which is homicide. So there are about 186 deaths every day from intentional violence in this country. 70% of those are suicides, and of all the suicide deaths, more than half are related to firearms. Again, it's the most lethal mechanism by which you can attempt to commit suicide. And again, most of those patients are successful. We don't see them in the hospital. About a third of our homicides and 75% of homicides in this country are firearm related. So in 2019, that translates to about 40,000 deaths from firearms, 60% from suicide, 36% from homicide, 1.3% related to law enforcement interactions, and 1.2% from unintentional discharges. When you calculate the potential years of life lost because of the impact that this problem has on young people, you're looking at almost 1 billion years of life lost. And the burden, of course, of this disease is much larger because we have no database and no way to track non-fatal firearm injuries. So if you look at it over time, this is looking at both suicide and homicide in adults. There was a fairly big peak in homicide in the early 1990s that was related to the crack cocaine wars and a lot of urban violence, and that came down. But over the last few years, it has been rising, and you'll note that this is all pre-pandemic. I'm going to show you pandemic data in a minute. It's not any better. And you can see that suicide was on a pretty steady rise prior to the pandemic. When we talk about suicide, as I mentioned, about half of suicides in the US are related to firearms. And the data would suggest that 85% of the time, if you attempt to commit suicide with a firearm, it's fatal. And so again, our chance to rescue these patients is very limited. The data would also suggest, though, that if those that attempt to commit suicide by other means, where they're not successful, the likelihood of them trying to commit suicide again is very low. So the fact that we can intervene and provide support to patients after a suicide attempt gives us a chance to save a life, and we don't have that chance with firearms. This is data in children. Again, a big peak in the early 1990s in homicide that came down, but again has been rising over the past few years. Again, pre-pandemic data, and suicide also on a very steep rise prior to the pandemic. Does vary some by state. You can see here in Washington, the lighter color is better, but we still have a fairly high rate of adjusted death rate from firearms. But the highest rates are, you can see here, in the South and in some rural states as well. What gets the most attention, and certainly has been in the news media in the last couple of weeks, are the horrible, horrific mass shootings that we've seen. The most recent ones are not on this scale, but I want to just give you a sense of how this has evolved over time. And if you go from all the way from 1966 to now, you can see that we have a problem. We have an increasing rate of mass shooting violence, clustering in the last few years. And the top circles are fatalities and the bottom circles are injuries. This huge circle here is the Las Vegas shooting, which was the most devastating shooting that we've had in this country from the rate of both death and injury. So what's happened during the pandemic? Well, it hasn't gotten any better. I'll show you the data, but the first thing that's notable is that the rate of firearm sales has increased dramatically. You can look at it a couple of different ways. You can look at the rate of background checks for legal firearm sales, and this was the rate in 2019, and then in 2020 it was significantly higher every month and rising. And you can also look at it over time, and this is pretty sobering data that shows you what happens with some of these events. It'll be interesting to see what happens now. But after Obama got elected, there was a big spike in gun sales because there was concern that people would pass legislation restricting sales. After the Sandy Hook school shooting, over 2 million guns were sold. Again, a big spike, and about the same over the course of the pandemic. So whenever something happens, more people buy more guns. What is that translated to? So here is 2020 compared to 2019. So again, you can see every month of the year, a very significant increase in firearm injuries and deaths. And then over time, this big spike here in homicide during the pandemic, suicide, we're still assessing whether that's going to rise, but I think it's going to be a little bit more delayed. But also children being home during lockdown was associated with significant increases in unintentional injury and domestic violence. What's happened at Harborview? So Harborview, is a pretty busy trauma center. We see pretty much all of the firearm injury in King County. And we were running pretty steadily at a rate of about 300 firearm injuries a year. And here you have the impact of the pandemic. And we're now over 500 injuries a year. So it's gone up more than 30% each year over the last 2 years. If you look at King County data, here you're comparing the first quarter of 2021 to the same quarter before the pandemic using a rolling 4-year average. Shots fired were up 25%. Number of shooting victims overall up 27%. Number of fatal firearm homicides victims up 36%. Non-fatal firearm injury up 25%. And the demographic suggests that we, like most other cities, have a significant problem in the African-American community, and there are a lot of social issues that feed into that, but about 80% male, 42% between the ages of 18 and 24, and 78% of those shot in King County are people of color, when our population is 6.8%. So it seems almost a little bit like we should just throw our hands up in the air, right? It seems hopeless. We see mass shooting after mass shooting after mass shooting, and if you work in a trauma center like I do, you see people every day who are getting shot. It seems like nothing can be done. And as I mentioned, though, this cross, it was pretty significant, the crossing of these lines in 2017. But look at what's happened with motor vehicle collision fatalities over time. We've made some progress there. So the question is, how have we made this progress, and can we learn something from that? So I want to take you back in time, and I want you to imagine that it's 1966. And you notice that there's really high rates of fatality in motor vehicle collisions across the United States. This is a time period when there's no safety features in cars, there's no seat belts, there's no airbags, there's really nothing. And this is Ralph Nader, who is a very activist lawyer. Many of you probably remember him, who wrote this book, Unsafe at Any Speed, which really caused a lot of political controversy because it really upset the car manufacturers. It accused the car manufacturers of ignoring safety in the design of their vehicles, whereas they just wanted to blame the driver. What happened was he testified before Congress, and Congress actually decided to act. So in 1966, the National Traffic and Motor Vehicle Safety Act was passed, which was not popular with the car manufacturers, but it mandated seatbelts, padded dashboards, and shatter-resistant windshields. Those are the first safety features to appear in motor vehicles. But I think more importantly than that, they established the National Highway Transportation Safety Administration. So they made a long-term investment in setting up a federal agency that was going to track and work on vehicle safety and roadway safety. This included establishing data systems to track all fatalities across the United States and a research infrastructure that was funded to study the biomechanics of injury. I had the opportunity to work at the Harborview Injury Prevention and Research Center for a number of years on this project that was funded by NHTSA, where we would enroll patients who were involved in motor vehicle crashes that came to Harborview that had serious injury. We would collect all of their medical data, their imaging, and then we would go out and we would reconstruct the entire crash. We would determine exactly how that injury occurred in that vehicle in that crash. And that data would go into a system where they could look for patterns to try to identify opportunities for improvement. A couple of papers that we published from that data looked specifically at spinal cord injuries and deaths in rollover collisions. And in a rollover collision, it's all about where the roof comes in and how it impacts the individual. And you can imagine that that roof there hitting the driver is going to cause their neck to flex forward, and they can have significant spinal injury. It turns out that the roof crush regulations, and they had to do tests where they have to test the strength of the roof of a car, had not been changed since the 1970s. And not too long after these two papers were published, NHTSA looked at all this data and passed a regulation requiring all new cars to have a stronger roof. So it's a great example of how if you set up the systems to collect the data, you analyze it, you look for opportunities for improvement, you can make interventions that make a significant difference. And most of us take for granted all of the safety features that are in our cars today. So if you look at a classic way of looking at injury prevention, it's called a Haddon's matrix. You look at the many different ways that you can intervene on a problem. And we've really, I think, taken this multifaceted approach to motor vehicles, right? We look at issues around the driver. What training do they need? What skill set? What issues do we have with distracted driving? How can we reduce that? How do we get people to wear their seatbelts? Those sorts of things. We've looked at the vehicle, and we've done work on anti-lock brakes and vehicle design and airbags and seatbelts and all those things. We've looked at the physical environment, and we've looked at how our roads are designed and do our guardrails crumple when you hit them? And, do speed signs break away? How do you design a median so somebody can't cross and drive in the opposite lane of traffic? And then we look at social issues around traffic and law enforcement. So this comprehensive approach to motor vehicle prevention really has led to the results that I showed you. It hasn't been without legislation that's gone along with it, of course, right? And the creation of the National Highway Transportation Safety Administration was just the first step. It was followed by mostly state-based laws. So car seat law, the first car seat law was actually in Tennessee. First, a seatbelt law in the United States was in New York. And over time, these spread to nearly every state, and all states now have seatbelt laws except New Hampshire, where you are supposed to live free and die. So if you look over time, you can see that again, we've made a substantial difference. So while we have more and more cars on the road, more and more people driving, this is vehicle miles traveled in the tens of billions, our deaths related to motor vehicle collisions have come down substantially. And it's because of this structured systemic, multifaceted approach to dealing with the problem. So what do we learn? Well, obviously you need activists. We need people that raise awareness. We need the Ralph Naders out there beating the drums, writing the books, testifying in Congress. But we also need mechanisms to establish and collect data so that we can define and study the problem. And we need federal support for research. And that's been a particular challenge in firearm injury, which I'll talk about. And then you need to engage a broad range of stakeholders. We need Mothers Against Drunk Driving. We need all of those groups that worked very hard to try to address these issues in a multifaceted way. And I love this picture. This is a picture from a talk by James Carrico, who is a famous trauma surgeon. He gave this talk at the American College of Surgeons back in 1998, and way ahead of his time. And he talked about the multifaceted approach that you could take to injury prevention in automobiles. And he said, you know, in automobiles, we've taken steps in almost all these areas, but in firearms, we have focused on only one thing, and that is the gun. We have not really taken a multifaceted approach. And I think that this was really wise words well ahead of its time. So you all know, and I'm sure I'm preaching to the choir a little bit here, but I think that we get mired in this problem because of politics. And because really we have two different stories around firearms in the United States. And it depends a lot on where you live and how you grew up and your experience and those around you. But I think if you break it down, we have really two contrasting narratives. We have those that feel really strongly that guns are a part of our history, our culture, and that, that they're a source of protection. And so therefore they equate guns with freedom. So if you use the term gun control, to that person, they're hearing freedom control. That doesn't go over well with them. Likewise, we have folks who feel like guns have no place in our society. They're really just a source for propagating violence, and violence limits freedom. And so gun control sounds like violence control, and that sounds pretty good. So you can imagine how we retreat into these two camps and then nothing gets done. Are we getting any better at this? No, right? This is a Pew Research poll that looks over time at, and the question was the percentage who say it's more important to protect the rights of Americans to own guns than to control gun ownership. And you can see that the divide, certainly by political party, has gotten wider and wider and wider, like in most things that we deal with. What about surgeons? So you would think surgeons, particularly trauma surgeons who take care of these patients like I do, would be, would have strong feelings about this. So we did a bunch of surveys to survey members of the major trauma organizations in the country and the American College of Surgeons. And we asked them questions about their fundamental beliefs about firearms. And no surprise to, well, it was a surprise to me at the time, but now I understand, is basically we're split the same way as the rest of society is. So about 44% said firearm ownership is a critical liberty or right and it should be protected. And 40% said it's harmful and it should be limited. So it seems like this impossible chasm. Like, how are we going to cross this and get things done? We have people dying from firearm injury. We have to do something. We have to do something. So one of the things that we learned is that how you ask the question matters. So after we did those initial surveys of trauma surgeons in smaller societies, we decided we wanted to survey the entire American College of Surgeons. The American College of Surgeons represents all surgeons of all specialties in the US. So it's about 50,000 members. And when we did that, we hired a survey firm and they said, you're asking this question wrong. Because you basically have clumped two things together and you haven't given people an option to be in the middle. So when you ask the question about is firearm ownership beneficial or harmful, the vast majority of people say both. They're in the middle, right? And then if you say, does firearm ownership protect or limit personal liberty? Again, 44% say neither. So this to me suggests that there's a lot of middle ground that we have opportunity to make an impact. After that, we published this paper really trying to lay out those narratives that I talked about. And what we put forth was a common American narrative, what we hoped would bring people together to work together on this issue. And it goes something like this. We have to recognize that currently firearm ownership is liberty that's protected by the Constitution, but violence is a major cause of preventable death and suffering. And so perhaps we can work together to do two things. Our goal is to do two things. One is to understand and address the root causes of violence. And the second is to make firearm ownership as safe as possible, both for those who own firearms and for those who do not. So taking that framework, then now back into this sort of public health approach, how can we apply that? What can we do? What can we practically do that's going to make a difference? Well, the first step is we need better national data collection. We need to move beyond just collecting mortality data and collect data on non-fatal firearm injuries so we understand the full scope of this problem. We also need a way to combine law enforcement data with medical data so we understand the risks that go into these events. We need data on firearm storage practices and attitudes if we're going to understand how to intervene in firearm safety for those that own firearms. And we need a lot more detail around the circumstances of these events. So one of the first things we did was apply for some research funding, and this is a research project that we're doing through the American College of Surgeons to address that first question of national data on non-fatal firearm injury. We're enrolling patients from across the country into this study, giving us a lot more detail on the events surrounding the shooting in different parts of the country. And you can see that we've got trauma centers from nearly every state participating in this study. This data collection is just finished. We collected data for a year, and we should have some results coming out soon. So projects like that to start to better understand the scope of the problem. We've also done some work to really identify some of the risk factors, both around firearm homicide and suicide. This is a scoping review of the literature that goes through all the potential risk factors and really summarizes what we know today based on the research that we have. The next step, of course, is inform and educate, and we've been constantly working on this. This was a CBS Sunday Morning news story not long after our medical summit. Again, trying to get attention to the public health approach to this problem. And certainly, this is Dr. Stewart here. He's the chair at UT San Antonio. He was involved in treating victims from both the Sutherland Springs shooting and the most recent Uvalde shooting, and has been on the news media, I think, every day in the last 2 weeks. And the other thing that we thought about a lot was what can we do within our hospitals and healthcare systems? And one of the things that we don't do a very good job about right now is identifying patients at risk for firearm injury and asking about firearm ownership. So we really need to think about how we, as a medical community, develop routine patient screening. I think we've done a pretty good job in most places of screening for risk of suicide. We have questions now, on risk of domestic violence, but we don't think about our older patients. Perhaps somebody's developing dementia, but they have access to a firearm in their home. Have we asked their family about that? Have we developed strategies to help them remove the firearm from that situation where that person is at risk? The other area where we, I think, have not done a very good job is really screening for the risk of youth violence, right? And so we know that many of these patients will present to the emergency department for other injuries, other events, drug intoxication, other things, and perhaps we can identify them before and put them into services before they're shot. And so this safety score was developed by a group at the University of Michigan that's been working on this problem. We put out a number of resources for the medical community. This brochure, Gun Safety in Your Health, which is also translated into Spanish, is available for physicians' offices for helping physicians talk to their patients about firearm ownership and safe storage. And then we also worked hard to develop these violence intervention programs. This is a primer on how to set up one. This is really based off of the work of Rochelle Dicker, who founded the first major program at University of California, San Francisco, where Dr. Cuscieri is now, called the Wraparound Program. But these programs seek to enroll young people who are at risk to survive their firearm injury when they are in the hospital. It's a moment where they are realizing the consequences of this event for them. And if you approach them in the way that gains their trust with a trusted messenger, and we hire intervention specialists from the community who have, most of them have experienced violence themselves, you can really make a difference in enrolling these patients into services after discharge. So if you go to those two approaches that I talked about, both making firearm ownership as safe as possible and then addressing the root causes of violence, we can sort of start to take these apart and look at, again, multifaceted ways of tackling the problem. One of the most important things that I think we recognized early on, and I'm not a gun owner, so I don't speak the language of gun owners. And so you need trusted messengers. And so we formed this FAST work group, which is a group of firearm owning surgeons to work together for about a year to come up with some recommendations that they thought would help move the needle on this issue, and that the firearm owners, responsible firearm owners, would support. This paper was also published in JACS. This has gotten a lot of attention in the last couple of weeks because as there have been some bipartisan discussions in the Senate, we have tried to influence that by getting some of these into that discussion. So these 10 recommendations here, and I'm not going to read them for you because they're kind of small, but many of these are in the legislation that's been proposed in the Senate, not all of them. I would certainly like to get more of them in there, but these are strategies to address some of these issues in a way that at least might make some traction at this time. I think one of the most innovative things here, and we can talk about it more a little bit later, it's certainly not gotten any traction yet, but there is a National Firearms Act that was passed in the 1930s when Al Capone and the machine guns were all over Chicago, that set up a class of weapons called Class 3 weapons that were basically highly restricted. Those include machine guns, sawed-off shotguns, explosive devices. And they're the only weapons in that classification, but they are extremely hard to get and require extended background checks, approval of local law enforcement, and so forth. And in the 1980s, they subsequently were able to pass some legislation to ban the further manufacture of those weapons. So we think that one strategy to deal with the AR-15, which is, as you know, is highly lethal and being used in most of these mass shootings, is to consider reclassifying it. If you could put it in a Class 3 classification, along with machine guns, you're technically not banning it, but you're making it super hard to get. And that could ultimately lead to a ban in a way that doesn't cause as much political rancor as the all-out ban idea that's being pushed. So we're trying to get some traction on that idea. Other firearm safety initiatives that we've worked on around safe storage. This is a map that was produced by the group in Colorado. We have a similar one for Washington, where we have identified gun shops and police stations and places where basically you can take a weapon that you want somebody to store because you want it out of your home because you have somebody at risk, or you have a family member who's depressed and you're concerned that they might hurt themselves, or others. You can temporarily remove firearms and you can store them in a neutral place. This can be done by family members on their own, but also can be done with legal support in things like red flag laws and extreme risk protection orders, again, which are getting some attention currently, as a way to try to remove firearms from a situation where somebody shouldn't have them. Lots and lots of hospitals are doing safe storage campaigns, just like we used to do bicycle helmet campaigns, where you give out lock boxes or trigger locks and education around safe storage, particularly to reduce exposure to children in the home. All right, and the next phase of this is really looking at the bigger challenge of largely urban violence. How do we identify and address those underlying root causes of violence, and what can we do about it? And there's lots of different studies that have been done looking at the problem of urban violence, and there's no doubt that the social determinants of health that contribute to poor health in lots of different areas are also strongly associated with violence. This is a map of shootings per 1,000 population in Philadelphia, and you can see it overlays almost perfectly with the percentage of households below the federal poverty limit. This is a map of Chicago. Again, similar thing, looking at gun deaths and median income. And I actually saw, I don't have that in here, but I saw a slide the other day from one of Dr. Dicker's talks where she mapped where the Trader Joe's stores were to violence. And There's like a zone of no violence where the Trader Joe's stores are, and then there's violence where they're not, which is kind of interesting. So this gets to the concept that we have to deal with. We have to tackle the social determinants of health. You all are probably familiar with these, but poverty, education, housing, inequality, many of these stem from the problems of structural racism, of redlining, of creating neighborhoods where there's not the opportunity to advance. And what that leads to is a sense of hopelessness and the roots of structural violence. To address this, we put together a really diverse team, which we call ISAVE, the Improving Social Determinants to Attenuate Violence team. It's chaired by Dr. Dicker, who's now at UCLA. And they've worked hard on a number of different initiatives. They've developed a trauma-informed care curriculum for our hospitals to help form better trust with our patients and ensure that we're addressing their needs. They've worked to develop a hospital and community-based violence intervention programs. They're integrating social care into medical care. There's some novel strategies around investing in communities. There are hospital systems that are now supporting affordable housing in the neighborhoods. They're supporting green space and other strategies to improve the neighborhoods in their city. And then and health equity. For those of you not familiar with trauma-informed care, this has got a pretty good structure around it now. A lot of resources on the Substance Abuse and Mental Health Services Administration. But basically it's recognizing that our patients come to us with a whole series of life events that are usually not terribly positive, and that affects how they interact with the healthcare system. And so we really need to be conscious of these issues and think about how we can support patients in a way that is productive for them. There are really 6 key principles of a trauma-informed care approach. It's setting up safety, trustworthiness, and transparency. Providing that peer support is really critical. And as I mentioned, we at Harborview have hired a violence intervention specialist who's an African-American man who was a victim of gun violence himself. And he can immediately walk in the room and develop trust with a patient that none of us can any other way. And so really this approach we're rolling out now in 20 trauma centers across the US as a test. The goal is to train everybody in the center that cares for patients, that interacts with patients, and get some feedback. And then we're hoping that we can roll it out nationwide. When I talked about hospital-linked violence intervention program, I really think they used to call them hospital-based violence intervention programs, but they're really hospital-linked because they have to partner with community organizations. And I'll talk a little bit about what we're doing in King County. But the goal is to have the violence intervention specialists in the hospital, again, develop relationships with the patients, build their trust, but then connect them with community organizations that can provide the support they need to address their social determinants. It requires multidisciplinary follow-up. And then my dream, and we haven't reached this yet, is to have a trauma follow-up clinic that's just like a cancer clinic. If you go to see a cancer specialist, right, you're going to see the cancer doctor, you're going to see the radiation oncologist, you're going to see the surgeon, everybody in the same visit, right? You're going to have a coordinated, structured plan. Well, I think if you come back for follow-up from your traumatic injury, you should see the social worker if you need resources. You should see a substance abuse counselor. Perhaps you could see somebody for PTSD screening and evaluation for mental health. We need that kind of wraparound coordinated approach to the post-discharge care of our patients. And that's the ultimate goal that we're working towards. So what are we doing in Seattle? We're happy to be Harborview is part of the Regional Peacekeepers Collective. This is a collection of a large number of community organizations across King County that's really been pulled together by King County Public Health. These are all organizations that were working in the community and trying to improve these things and address violence in the community, but they were very disjointed. So bringing them all together in partnership, and we've joined that collaborative, I think is been really highly successful, and there's a lot of work yet to be done, but that's how we're trying to tackle this problem within the city of Seattle and across King County. What does this program do? It provides, again, intensive wraparound support services for high-risk youth and their families. It's important to recognize that the siblings of those that are injured are also at significant risk. In part, there's a retaliation desire that needs to be sort of de-escalated. And so we provide rigorous intervention for those involved in secondary prevention for younger siblings, and then follow-up care for the family. Since we've launched this, which we just launched in October 2021, we've enrolled 20 high-risk youth in the program, and so far their experience has been good. That's not to say that we shouldn't continue to push policy efforts as well, and these were some bills that we were working on, again, prior to the most recent events. There's a House Bill 5855, which is a bipartisan solution to cyclical violence, which provided grants to support the further development of these hospital-based violence intervention programs. We have been successful in getting some funding for federal research. You may know that federal research from firearms was restricted by the Dickey Amendment for many years. That was reinterpreted under the Obama administration and allowed the CDC and the NIH to start to fund some firearm-related research, but they had no funding to do it. And so through legislation, we've been able to get about $50 million, $25 million to the NIH and $25 million to the CDC over the last 2 years to support firearm research. And so we're starting to see this grow. Obviously, it's a drop in the bucket compared to the scope of what's spent on medical research every year, but it's a start. And then we've been actively supporting many of the universal background check bills that have been working their way through Congress. So what can we as medical providers or hospital systems do? I think that we can commit to some pretty basic things that can make a substantial difference. We need to screen for patients at risk for firearm injury wherever we see them, whether we see patients in the hospital, we see them in our offices, we're a primary care specialist. We need a screening strategy so that we can both screen for the risk of firearm injury and we can counsel patients. We can counsel them on safe storage. We can counsel them on lethal means safety. If they have somebody at risk in their home or a family member that's at risk, we can find out if they have a firearm and help them find a way to relocate that. We can support safe storage campaigns, providing lock boxes and trigger locks. We've done some of that through the Injury Prevention Center. We go to sporting goods stores and we go to gun sales and we try to engage people there in injury prevention. We can all implement a trauma-informed care approach, and I think we're all learning how to do that well. We can establish our hospital-linked violence intervention programs or peer support programs. There's a group called the Trauma Survivors Network that will provide volunteer peer supporters. Partnerships with community organizations, I think, is key. And then working on those social determinants, both in our admission and discharge planning. The new requirement for trauma centers to screen now patients for the risk of PTSD, which will hopefully increase our ability to offer mental health services on the time of discharge. We're screening for substance abuse and coordinating post-discharge treatment there. And we can all encourage our hospitals and healthcare systems to invest in the local community. They're usually the largest employer in the community in many places. And by investing in the community and investing in affordable housing and other strategies, it actually helps support their employees as well. So in summary, what I hope you take away from this is that violent intentional injury, I believe, is the most neglected public health problem in America, that it's all on all of us to commit with responsibility with action. If we take a public health approach rather than a political approach, I think that there's opportunity to make a difference. If we work together to both understand and reduce violence and then make firearm ownership as safe as possible. I think importantly, it's time to change the conversation. The term gun control, as I mentioned earlier, it pushes people into their corners politically and sort of turns them off. So we've really tried to focus on the term firearm injury prevention. What we want to do is reduce the rate of injury from these weapons. So I'll stop there again, just reminding you that everything I said is in this paper. So if you want to see any of the references or any of the literature, this is a great resource, again, published in the Journal of the American College of Surgeons in 2019. So I'll stop there. Really, again, an honor and a pleasure to speak with you tonight. I'm going to stop sharing my screen so that I can answer any questions that you have.
Thanks very much, Eileen. That was great. That really helps us develop a little bit different frame around this very polarized issue. The one question I have is people talk a lot about mental health. 2/3 of firearm deaths and injuries are with firearms. These mass shootings, the most recent ones, which were so horribly spectacular. And all of us know in healthcare that accessing mental health care, accessing healthcare at all, but of all of healthcare to be accessing mental health care, whether it's somebody in florid crisis or people who are just depressed, is really tough. And how do you think we might be able to move forward in that direction?
Yeah, I mean, there's no question that our mental health system is more broken than the overall health system. And so we need to find ways to increase access to those resources. I think that it's often in the mass shootings, mental health is often blamed as the cause, whereas most of people who commit mass shootings don't actually have a mental health diagnosis at the time. Doesn't mean they don't have issues, but I think trying to make that the scapegoat for all mass shootings is probably not ideal. Certainly, as you said, the majority of firearm injuries overall are from suicides, and there's mental health issue associated with that. But I think it goes back to how do we strengthen our overarching healthcare system so that people have uniform access. And we are at Harborview, we're going to be building a new behavioral health institute because we recognize the need for more resources in our community, but I don't know if that's going to be enough.
I have a question about gun control at the federal and individual state level. First question, I guess, is I think, are bump stocks outlawed nationally? The bump stock.
There was a bump stock bill, but I'm not sure where it sits now. There's a lot of variability from state to state, no question. Like Washington is actually one of the states that has some of the better restrictive laws. We have you have to be age 21 to purchase these weapons. You have to universal background checks in our state. I mean, we have better laws than most, I would say. I can't quote the bump stocks where that sits. I'm not entirely sure. That was used in Las Vegas, and it can take automatic weapon and make it an automatic weapon.
Well, maybe it's just some states have outlawed it, but I think I saw something positive there. But what about high capacity magazines? Can states out high capacity magazines repeating like AK-15? Can states outlaw them, or will this eventually get to the Supreme Court?
States can right now states can limit the size or capacity of magazines that can be sold in your state. And Washington has passed legislation. It's being challenged, so we'll see what happens in the courts. But Washington has passed legislation to limit magazine capacity size, I think, to 10 bullets or something like that. It's variable from state to state.
Yeah, I mean, maybe this is answered in this really watered down congressional bill that's being discussed recently. But so the idea of being able to inject the idea of a public health approach to gun violence in the congressional discussions, is that why we're now looking at the Senate concentrating on mental health improvements, which of course we need that, but is that what we're looking at, or is that part of what Eileen, your organization has been trying to inject in the congressional discussions?
So sadly, we have to deal with the political reality we have right now. And right now, nothing that the House has passed will even be taken up in the Senate, although the House has passed a number of the things that we've talked about tonight. The Senate won't even take them up. So to get anything passed in the Senate, you have to have 10 Republicans on board to get past the filibuster. So they put together a group of 10 Republicans, exactly 10, and 10 Democrats to try to come to an agreement. I agree with you. The agreement it's watered down and it's weak, but it's a start. It doesn't have nearly everything in it that we would want. Most of what we would want is in the House bill. But it has some improvements to the background check program. So now juvenile records, for example, which were not previously considered at all in background checks, will be considered. So there's some improvements there. There is some more resources and support for mental health, which obviously we sorely need. And that's, again, being driven by that narrative that the problem is mental health and not the guns, which we don't necessarily agree with, but we do need some more support there. So, I think we'll see what finally comes out of that. We haven't really seen the legislation yet, just sort of what the media is talking about. But there's no restrictions. There's no age limit for semi-automatic rifles. There's no talk of reclassification, and those are all things that we're trying to push.
I think if a market approach to healthcare really worked, mental health care and psychiatry would be the biggest business in the world, particularly in our country. I mean, there's such a huge demand. I think the roots are so deep. I'll never forget when I went to London about, I guess it was 14 years ago, to watch my son row over there. There was the local magazine, it's like the Seattle Weekly. And it said in there, it was a checklist. So you're coming to the city to start university. And it said, here's your checklist. And almost to the top of the checklist was make sure and establish care with the primary care provider. And so that's just a societal expectation there here. And I don't know about any of you, but you try to do that in this country. If you can find somebody that's taken new patients, even if you have established care, you're going to wait 3 weeks unless you walk into an urgent care or, an ER. So I think the roots are so deep that I remain hopeful. But I'm just, I just hope that somehow we can get this ship turned around before we hit too many more icebergs. And even if we talk a good game about mental health, the pipeline is so long to get that. Suzanne, you had your hand up?
Hooray, they're thinking about mental health. Now, the reality is that people with mental health issues are actually they're very not likely to be the ones engaged in violence. So becomes more and more and more complicated. And I don't know the answer to this. Are we no longer enjoined from actually doing public health studies about gun violence, which we were for a while? I don't know the answer to this. And if we're, sorry,
finish your question. I'm sorry.
No, we are still enjoined. Is that right?
No. So the Dickey Amendment, which was passed a number of years ago, that said basically you can't do any research that promotes gun control, was interpreted very strictly by the NIH and the CDC, that if you even had the word firearm in your proposal, it was rejected, right? But that was reinterpreted a few years ago under the Obama administration, and so now the CDC and the NIH are allowed to fund firearm injury research. The challenge then was they didn't have any money to fund it with. So over the last 2 years, we've had legislation that has provided $50 million, $25 million to the NIH and $25 million to the CDC, and they are putting out grants, and there are people that are starting to study the problem as a result. There's also been a number of philanthropic organizations that have come together. The Arnold Foundation put forth a number of funding opportunities for firearm violence research, and that study I talked about from the American College of Surgeons is being funded by that group to look at non-fatal firearm injuries. So I think that the evidence is growing and the opportunity to study the problem is growing. So we've made a little bit of progress there.
That part's very encouraging, and it's not like we don't already have like immense amounts of information. People are willing to look at it. I think we're facing the same thing that we faced, but in a very different time with seatbelts. Nobody's gonna make me wear a seatbelt, yada yada. And so, and we're in a time where there's this huge anti-science. As someone who spent her entire career in reproductive health and reproductive health rights, watching the anti-vaxxers talk about my body, my choice makes me want to puke. But it's the same kind of thing. As we even say the word, we're considering gun safety mechanisms, the sale of guns goes sky high. So we are in a place where my answer is to do everything we can to replace all the Republican local legislatures and governors. And it's a Sisyphean task. And I'm just so grateful that I live in Washington.
Well, thank you for that, Suzanne. And I did talk in the talk quite a bit about the story of motor vehicle safety, and it was incredibly controversial about wearing personal freedom and wearing seatbelts. It was a lot of pushback from the car manufacturers about requiring safety features in cars and to drive up the costs and all these other things. But we've overcome that. So, I think we should learn from that as we try to tackle some of these issues.
Ralph Nader, still has an hourly program every week on the radio. It's pretty good.
Yeah, Eileen, great talk as usual. Always learn something new as every time you talk. So thank you again. If I could just bring up a question for you. You demonstrated and you showed again that this is not an equitable problem. This is unfortunately affects our underserved, under-resourced, our minority more than it does our majority. And as you try to develop these programs to really assist in gun violence prevention, and you're developing it in Seattle, how are you reaching out? How are you communicating with the community, which is unfortunately affecting more than other communities, to really engage them? And what strategies do you have for others who are trying to develop similar programs to actually make this work?
Yeah, I think that's where you need to know what's already happening in the community. So there were a huge number of groups working particularly in Seattle and King County, on this issue but not in a coordinated way. And they were doing, terrific work in the community, building trust and supporting people, providing job training for young people. So it was a matter, I think, of bringing all those groups together, which I think King County Public Health has done a pretty good job of doing. And then figuring out how we as a hospital could partner with them to say, okay, we've got young people who we see sometimes more than once, who are shot. So let's find a way to provide support to them before they leave the hospital so that they're plugged into these resources and their chances of being re-injured are reduced, and their siblings are also protected. So it's not none of these are easy solutions, right? Because you're tackling really big societal problems, right? Poverty and homelessness and all these big issues that we're trying to tackle. But if you can take those that are at greatest risk and provide them the services and plug them into their own community organizations that really want to support these families, we're hopeful that that's a good strategy. It's worked in San Francisco. I think from your time there now that the wraparound program is one of the model programs for the country, and it really has had a significant impact there.
But I guess if I could just follow up on that, how do you get our leaders to really understand that? Because the funding has to come from someplace. These programs are not cheap to run. They're expensive to run. People are doing it as volunteerism, but that can only go so far. And when people don't believe in racial division, when they don't believe there's inequalities, and they think this is unique to just mental health problems, because we do focus a lot on mental health, how do we actually engage our leaders to actually see this as a real problem? Yeah.
Well, again, I think there's lots of data. I showed you a little bit of it from a couple of cities, but there's lots of data that show the overlay of these problems, and it's fairly clear the associations between social determinants and the risk of violence. I think that so sharing the data with them, I think, is the first step, making sure they understand the scope of the problem. I think it's incumbent upon us to show the effectiveness of these programs too, right? To be able to show that we can reduce the rate of re-injury, that we can reduce the rate of incarceration and things like that through these programs, so that they're willing to invest in them. They are almost all existing off of grant funding. Our program is existing off of federal grant funding that King County was awarded. But there's, some states that have issued funding. For example, the state of New Jersey has developed an entire gun violence research center and provides support for their hospital-based programs. So it is variable from state to state where the money comes from, but there are sources of funding if we can prove that the programs are effective.
Just thinking about how to get that word out. I mean, if you looked at that CDC white paper, Means Matters, and I think you had a couple slides from that. Some of that information there that was accumulated before the Dickey Amendment was really amazing, of, how successful firearm suicide is, the fact that it affects young people, and the fact that it's an impulsive act with something that happened in the last 2 hours. And, the young guy that bought that AR-15 down in Uvalde, I mean, he bought it, he didn't even have the money for it. He bought it on kind of a payment plan. So you don't even need cash in some places. But, and you look towards the media has become, unfortunately, even public media. I'm thinking, how about a program with Frontline that interviews people like you and Ronnie Stewart and others like that, Frontline or PBS or Michael Moore to pick up the banner to really get this information out. Having spent a very brief time in the U.S. military and looked through a slide set of what those high velocity weapons do to people, and I know they couldn't even identify those children except with DNA and who had what sneakers on, because basically those weapons explode a human body. They're not a bullet hole. I mean, particularly if you get shot in the head with one of those, I mean, it will explode the head. And I can only imagine the horror of those children and teachers who survived, or even the first responders. But I really think we need, like the Alliance for Gun Responsibility, or we need a media partner to get the word out. Yes, Suzanne, you had something else.
So I was just going to say that 60 Minutes did a very nice story, very nice, but a very good story a few years ago on the high velocity rifles, and actually showed in a lab, they took this gel mold that was same consistency basically as a human torso, and they shot a regular pistol through it, and then they shot a high capacity weapon through it, and they videoed the deformation of the gel, and talked a lot about the severity of these injuries. And so there have been attempts to try to cover that in that way, and but it's there's a lot of media noise, and it's hard to get through, I think.
In keeping with this end of the discussion, this is a question to which I don't even begin to think I have the answer. But they talked about should we be asking parents to allow photographs of the actual children in an effort to make people understand what these weapons do. And I agree, it's a very fraught question, but I'm just curious about what wise minds in this group think about that.
I'll tell you my personal opinion on it is I think that, once a photo like that is out in the public domain, it's there forever. And I worry about the siblings of those kids growing up. I worry about the risk of their mental health, their secondary trauma by being exposed to that. And I know that this was asked of the parents after Sandy Hook, and they uniformly, as a group, said no. That they didn't want that. And I think I can understand that.
You know, it's amazing though, because I don't think people really understand, and I can understand a family's opinion about that. But I haven't seen that 60 Minutes presentation, and I need to, but I mean, you can, even if you did it with animals, people would take offense, but people just don't understand. I have a brother who was a Marine during Vietnam, and he wrote a piece about one of his colleagues and friends who got hit in the head and lay dying in his arms. And he rewrote that in honor of the children of Uvalde, because, and he's a teacher, and he said to his social studies class, if I still have problems with that event 60 years later, how do you feel it's going to affect those children and their families? So I think there's a lot of understandably but intentional ignorance that we allow to prevail, because people just don't understand how horribly dangerous these weapons are. I mean, it is truly phenomenal. I mean, if you shoot a can of sauerkraut with one of those weapons, it explodes. I mean, it just explodes. So it's a tough question. There's so much that is rooted in our inequities that drives our political polarization that I don't know. It is a Sisyphean task for sure, Suzanne. Anybody else have any comments? We're about ready to wrap up at 8:30, but any closing comments, anyone?
I think, was it Eileen just made mention of how being in a situation like that, the rest of your life, you can't get away from it.
That's right.
Like you talked about your brother in Vietnam, I guess, but think of all those kids in the past couple months who were sitting next to their classmates, and that's going to have a big effect on the rest of their life.
Eileen, thanks so much for taking your time. You're a very, very busy person. Thanks, Joe. I don't know the rest of you, but Joe is also the chief of trauma and the chief of surgery at San Francisco General. And thanks for joining us tonight. And everyone else taking time out of your busy evenings with your family and friends. And I just want to thank everyone, and particularly thank you, David, for all your hard work helping keep the chapter going and keep things together. So without further ado, then we'll say good night. And again, thanks to all of you for joining us.